To Dr. Rohit, where he'll be discussing the capsular challenges in posterior polar cataracts. Yeah, I don't need.
I think which practically everybody asks, which should be also clarified, that at what stage, suppose CAPSULORHEXIS has been done, and there is an anterior capsular tear. The question is how to proceed now. Because the answer to that is, the first test is when you inject visco, if the flap moves or it becomes everted, that is the first sign that it is preequatorial. And if by any means, when you put in the phaco, with the fluidics also it will move. If it moves, this means it is preequatorial. If it doesn't, then it means it is postequatorial. You better convert. So that is one thing which I feel we should add to the whole scenario. So I would be talking about posterior polar cataracts with pre-existing posterior capsular defects. Well, the challenges in posterior polar cataracts are basically because of the fact that the PC rupture is there because there is a predisposition and we have whole lot of consequences involved in it. And there are situations around wherein the pre-existing posterior capsular defects are pre-existing in nature. So this PPC with pre-existing PC defects, the Daljit Singh sign is there. A defective capsule in the PC in the second eye is indicative that it can be a pre-existing defect. The earlier in life the patient presents with symptoms, the greater the likelihood for a defective capsule. Slit lamp examination is also obligatory and mandatory, wherein you will find that there are, particulate matters just behind the posterior capsule. OCT, I think we'll go into it in the next talk about the OCT findings to elucidate the pre-existing or the integrity of the posterior capsule in a posterior polar cataract. As far as the anesthesia is concerned, well, it's all surgeon's choice, what you are comfortable with. People like me at times mostly go in for topical anesthesia, but if you feel that there's a likelihood for a prolonged surgery, subtenuous infiltration can be also done. So let's go into things step by step. So this is a posterior polar cataract wherein you will find that there is a pre-existing defect. Now the first thing is the site of incision is very important. By any means, this site of incision should not be parallel to it. So there has to be an angle to it. The second most important part is the side port one. Because we need a stable chamber settings, by all means we do not want an undue efflux of fluid from the side port. So side port incision, the stepchild should also be taken care of. So side port calibration and site of incision relative to the axis of the posterior capsular tear is also very important. Next is the CAPSULORHEXIS. As far as the CAPSULORHEXIS is concerned, we need to have a small rhexis for some reasons and a large rhexis for some reason. So the way out is that you go around with an oval rhexis. Now this oval rhexis has quite a few advantages. Primarily, it gives the advantage of a large rhexis, all the features which a large rhexis has. There is no rise of intracapsular pressure. There is safe end-to-end sculpting. There is easy division, easy subincisional cortical removal, and smooth IOL implantation. As far as the small rhexis is concerned, optic capture, nucleus piece retention, and tamponading of the vitreous is there. Hydro procedures we have to decide. By any means, we do not want hydrodissection to be done. And wherein we cannot do hydrodelineation, then we can do no hydro procedure phacoemulsification. So here the patient was young, there was hardly any nuclear sclerosis. So what was done was step by step, layer by layer hydrodelineation. So in PPC, as I've already told, no hydrodissection, layer by layer is done. And in patients wherein the nuclear sclerosis is there, you can do cross-chopping with no hydrodissection and hydrodelineation. Coming to the next one, So let me explain how this case went on. Hydrodelineation was started. This hydrodelineation, you have to be careful. This has to be slow. Why it has to be slow? Because of the fact that at times we end up with the situation wherein we can have accidental hydrodissection and the whole thing can get undone. So what I am trying to do is what Dr. Vajpayee elucidated way back, that I am going to have layer by layer hydrodelineation. So you can find now 1, 2, 3 layers. So what we are going to have is we are going to have a cushion. We know that there's an open posterior capsule behind. So what I am trying to do is I am trying to take out the inner layer. So this inner layer is being taken out, and you will find there's hardly any CDE being used. So it is only just phacoaspiration which is being done. So you can see now I'm just trying to reposition the inner core. Once that inner core is gone, next comes the core outer to it. So that is the peripheral layer. So you can reposition your phaco tip in such a way that you are able to aspirate from sideways, and you can always reposition these nuclear, soft nuclear layers or epinuclear layers. You can see how I am doing it. CD you will still find it is 0, and IOP is 42. This was an old one. Once with all these outer layers done, I'm going to take out the outer layer. Still at this point of time, the open PC has still not been exposed. So I've taken care of the inferior one. Now I'm believing in doing stable chamber settings. I would like you to see what I'm doing now. What I'm doing now is, ideal situation when you have an open posterior capsule is that you should do a bimanual one. Why a bimanual one is done? Because of the fact that we want that there should be a different plane of irrigation and a different plane of aspiration. Here, the trick which I have done is, I have retracted the sleeve. This retraction of sleeve is a compromise, no doubt. Having a bimanual is a much better one. But this is a way how we can have a biplanar with a coaxial one. So what I have done is I have retracted the sleeve. That is the first thing. And then my idea at this point of time is that by all means, I am not going to expose the posterior capsule. So what I'm going to do now is I'm going to use epinucleus as a shield. So now what is this epinuclear shield? I'm going to take it, I'm going to disengage it, and I'm going to dislodge it from its peripheral attachments, and I'm going to keep it there. I'm not going to aspirate it whatsoever. You will find that I'm dislodging it, and after dislodging it, I'm leaving it there. And then what I'm doing is, I'm just trying to take out the subincisional one. Mark my words, till this point of time, the open posterior capsule has not been exposed to any fluidics, direct fluidics whatsoever. So I'm using epinucleus to my advantage by creating an epinuclear shield. And now comes the this is the second last one, wherein I'm trying to dislodge the last lodged epinuclear cortical matter. So once this is the last one which is coming, and here you will see that it has been done. So without exposing it, there's hardly any cortical matter which has gone behind. Now I'm just trying to inflate the chamber because I don't want any decompression. So now comes the trick in doing posterior capsulorhexis. It has already extended, but what I have seen in my experience that you can invariably create a round of capsulorhexis also. The first point is don't go through the main port, because by all means we do not want an unstable anterior chamber, because if by any means when you are using the capsulorhexis forceps, if the chamber is unstable, there can be a vitreous herniation and you can destroy the anterior hyaloid phase. So I'm using the side port, and with the microforceps I'm rounding off the capsulorhexis margin. So this capsule, I'm again inflating the chamber, and I'll complete the rhexis in a nice way. One part is already done. Then I'll go through the other side port, create another side port, and round off the capsulorhexis margin from the other side. So this part done, I have created a situation wherein the capsulorhexis is like this, and we have an elliptical one. The patient was young, and he had high expectations. So I am doing triamcinolone staining just to exclude or include the presence of vitreous, which was not there. I'll be implanting I could have implanted a single piece one in the bag, but I do because the lifespan of the patient was more. So I'll take advantage at this stage of the oval rhexis and do an optic capture. The small rim would help me have an optic capture. So you will find now it is in place, one in the sulcus, and I'll replace it so that it goes, now it is fully in the sulcus, and I'm going to capture it. So this is what it is, how we can manage in an adult. These were the results in these patients. This is with a pre-existing defect in which the nuclear sclerosis was grade 2 to grade 3. Do I have 2 minutes for this? Yeah. So I'll just continue. You can see a linear, posterior capsular rent in that. So I'm going to create a valley. And once I create this valley, the next thing is it has to be end to end so that I am able to create a situation wherein I divide it, and the division has to be complete. This complete division without marked separation, because I really do not want to put stress. Here comes the cross chopping. You do the cross chopping. So when you do the cross chopping, the nuclear fragments which are adjacent to the 6 o'clock one get eaten up, emulsified. So now you have a space created in this. Once that is done, you can see how I am taking it out. It's slow motion. You need not go fast. I am just moving it fast. You can see now this has been taken care of. Now I am trying to dislodge, and here you can see how I am managing it. By any means I am not rotating. I have not done any hydrodissection or hydrodelineation because I am somehow not comfortable in doing hydrodelineation in a patient who has nuclear sclerosis and he happens to be in the elder age group. Now the last nuclear fragment or the epinuclear fragment is coming out. Sorry. So once that is done, so here it is. Now I'm doing with the dry irrigation, dry aspiration, and the IOL will get into place. A multi-piece IOL. Here it was an open posterior capsule with no rounding off because that was not possible, and the case was duly completed. Thank you very much. So flax I will not be dealing in because of paucity of time. So basically this I am not showing. So summarizing, we have to have a preoperative diagnosis, preoperative and intraoperative OCT. We have to have a specific technique. Not always are we able to complete it because there are times when we can have a nucleus drop. So we need to have a total